So hello, everyone. I can see that there's still attendees coming in, but we're going to go ahead and start. So this is the May 2022 Heart Muscle Talks, which will be a lecture from Professor Elliott. We will play the recorded lecture, and if you have any questions, the best way is to write them in the Q&A using the Q&A button at the bottom, or you can later on raise your hand and we can unmute you if you want to ask your question live. We will have around 20 to 25 minutes for discussion. So then I will hand over to Professor Rapezzi to make the introduction.
Good afternoon to everybody. We are very curious for this hopefully interesting, fantastic lecture. Also, the title is quite challenging and amazing, and I'm sure it will enrich our culture. So thank you again, Perry, for this initiative and in particular for this talk. And please, let's go on.
So thank you very much for the kind introduction, and it's a great pleasure to be able to talk to you today about this vexatious subject, arrhythmogenic cardiomyopathy. And perhaps, as you can tell from the title that I've chosen, I want to be a little provocative and to stimulate discussion in today's session. The title itself is drawn from a novel written by Conan Doyle, one of the Sherlock Holmes novels, A Scandal in Bohemia. And here you see this extract in which Holmes is, in his customary way, torturing poor Watson. Watson says to him, "When I hear you give your reasons, the thing always appears to me to be so ridiculously simple that I could easily do it myself. Though at each successive instance of your reasoning, I am baffled until you explain your process. And yet I believe that my eyes are as good as yours." And he responds, "Yeah, quite so. You see, but you do not observe. The distinction is clear." And it's this seeing rather than observing, which I think is one of the fundamental limitations of our current approach to many heart muscle diseases. Now, when we're talking about cardiomyopathies, I have a tendency to go back in history because I think we learn a lot from the writings of thinkers in the past. The term cardiomyopathy itself, as far as I can tell, was first used by this cardiologist, Wallace Brigden, in London in the 1950s. And at that time, he made these statements. The common cause of isolated myocardial disease is coronary disease, but there are many other causes, mostly obscure and relatively rare. When patients develop apparently causeless heart failure, diagnosis of myocarditis is sometimes made, but usually the condition is attributed either to a previous hypertension or painless coronary disease. How often have we heard that? Often such patients die unexpectedly, and pathological investigation may not reveal the cause and nature of the disease. He goes on to say that the term cardiomyopathy in this lecture that he gave in 1956 is used here to indicate isolated non-coronary myocardial disease. Now, in the interval that followed, with growing sophistication of cardiological investigations, we started to develop this approach to the classification or the nomenclature for heart muscle conditions. And this was entirely based upon morphology and function of the heart. So if the heart is thick and unexplained by, for example, hypertension, we call that hypertrophic cardiomyopathy. If the ventricle is dilated and poorly functioning, we call that dilated cardiomyopathy. If the heart is neither thick nor dilated, but simply stiff, we'll call it restrictive cardiomyopathy. And this approach to the grouping of cardiomyopathies persists to this day. The only major change that's been made in the past 50 or 60 years or so was the inclusion of this entity, initially ARVD, or arrhythmogenic right ventricular dysplasia, because it was felt initially to be a developmental abnormality, what we would now call ARVC. And in 2007, by the ESC Working Group for Myocardial and Pericardial Diseases, a slight reorganization of this morphological approach combined with a deliberate question, if you like, is are we dealing with familial or non-familial disease, recognizing that each of these phenotypes can be caused by a range of very different disorders. Now, what I'm doing today is to focus on ARVC, and the reason I'm doing that is because it's a very timely discussion for us to have, because as I hope I'm going to show you, we've got ourselves into a bit of a muddle, a bit of a mess in terms of our understanding of the phenotypes that are embraced by this and some of the other terms that we've been inventing in recent years. And this is going to be really important as we move into a whole new therapeutic era in cardiomyopathies. Getting the phenotypes right is going to be really important. So if we just consider the narrative for ARVC, remember that as human beings, we tend to communicate in stories. And in medicine, the story often begins with the more extreme phenotypes. So, go back to the 1980s or even earlier, there were patients who were dying suddenly, and they were found to have this very characteristic appearance in the heart with this sort of thinning of the free wall of the right ventricle, allowing you to transilluminate the ventricle such that it was paper thin, affecting what was called in that era the triangle of dysplasia, in other words, sparing the interventricular septum. At the same time, clinicians were describing clinical phenotypes where there were electrocardiograms showing features consistent with a right ventricular pathology, with T-wave inversion, for example, associated again with ventricular arrhythmias of right ventricular origin, as you can see here, VT with a left bundle morphology and superior axis. I suppose the defining pathological feature of this disease that was described at the time and brought all these clinical paradigms together was the fact that what we saw at post-mortem was a replacement of the myocardium, shown here in brown, by fat. So this was seen as a disease of fatty replacement of the myocardium in the right ventricle. We went through a phase where that was a little tricky because we soon learned actually fatty ingress into the myocardium is actually a normal phenomenon. And the key point was not only is it fatty replacement, as you see through the section of the right ventricle, and the fat here shown in white, but there was also fibrosis, as shown here in red. So you can see here in this right ventricle, there is all just a simple remaining rim of myocardium in the subendocardium. The clinical characterization, again, continued to progress. So emphasis on right bundle branch block, on T-wave inversion, on ectopy or ventricular arrhythmias of right ventricular origin, of features consistent with abnormal conduction within the right ventricle, so after depolarizations on the surface ECG, or is detected through, for example, signal average ECG. For a long period, and certainly for my formative years as a research fellow, we spent a huge amount of time trying to diagnose this condition using ultrasound. And of course, in some patients, it's relatively straightforward when you see a dilated right ventricle like this, but actually detecting these characteristic abnormalities in the free wall of the right ventricle is extremely hard using echo. And the transformative technology here was magnetic resonance imaging. Here, a gross example, which would be detected in pretty much any form of cardiac imaging, where we can see dilatation, but areas of hypokinesia, aneurysm formation. But in more subtle cases, MRI has become the tool of choice, I think, for detecting the disease. The final chapter, I suppose, in this sort of evolving narrative for the disease was the unraveling of its genetic basis. We reckon as soon as you start studying patients, you realize that they have family histories of sudden cardiac death or unexplained cardiomyopathy. And the first gene to be identified was on the island of Naxos, where there were families that had a particularly malignant phenotype of early sudden death associated with ARVC at post-mortem, and a curious hair and skin phenotype. Work by Nikos Protonotarios and Adelena Tsatsopoulou on Naxos, together with Bill McKenna and co-workers, led to the identification of a 2 base deletion in the gene plakoglobin. Now, this was a recessive disease, and the overwhelming majority of patients that were seen then and that we continue to see have dominant disease. But this established the paradigm of ARVC as a disease of the desmosome. Mutations in plakoglobin appear to be extremely rare outside the recessive disease that's seen in Naxos and a few other places in the world. But mutations in the other proteins that make up this structure, the desmosome, desmoplakin, desmoglin, desmocolin, plakophilin 2, these have all been implicated in ARVC. So we put that all together, the novel of ARVC put together, we have a disease which is defined by structural abnormalities, a characteristic histological phenotype, if you like, electrical abnormalities with characteristic ECG findings, and of course, ventricular arrhythmia and its correlate sudden cardiac death. Now, if you put all that lot together, as has been done on a couple of occasions in the development of diagnostic criteria, you end up with this kind of paradigm in which you diagnose a disease according to structural alterations, tissue characterization, ECG abnormalities, arrhythmia, and of course family history or genetics. So complex, but I think a very clearly defined story. But this was the stimulus for the title I chose for this lecture. You see, Watson, but you do not observe. I showed you this slide earlier of the characteristic histological appearances of ARVC with the replacement of muscle by fat and fibrosis. But even in this classical image, we can, if we look carefully, see evidence here of something going on in the left ventricle. When we look at ECGs from the first patients being described with ARVC, there was this inconvenient presence of inferior changes, of an inferior infarct pattern, the correlate to this histological abnormality. And as soon as we started applying MRI scanning to individuals and families, we started seeing correlations between the structural histological phenotype of fibrosis and fat with scar within the left ventricle. And sometimes, as you can see here, far from being a characteristic ARVC ECG, this is what I might term a more left ventricular ECG. And similarly with the etiology, whilst we had this became a disease defined by mutations within the desmosomal genes, over the years, other genes have been implicated in so-called arrhythmogenic phenotypes. Phospholambin, desmin, lamin AC, a number of different genes. So even at a genetic level, we're starting to see a lot of heterogeneity. And actually, you could look at several papers in the literature showing that there is a clear sort of broad phenotype emerging in that some of these genes seem to have the particular predilection for the right ventricle here in this study, looking at the prevalence of left ventricular dysfunction, relatively uncommon in PKP2 related disease, but much more common in desmoplakin related disease. And this, I think, gets us into a bit of a muddle when we start to look at patients in the so-called real world. Here's an example of that. So this is a patient who has a known desmoplakin mutation, a frameshift mutation. He's 67 years of age and is referred for screening because of a family history of sudden cardiac death. He has 500 to 900 ventricular ectopics over 24 hours, plus non-sustained VT on multiple ECG recordings. Here is his electrocardiogram. This is a highly informative electrocardiogram because it shows sort of right bundle morphology pattern, but also you can see loss of R wave, particularly again here in the inferior leads, but throughout all of the leads. And what we see on Holter monitoring here is the presence of non-sustained ventricular tachycardia. And then if we look at the imaging, we see here a ventricle which is a little bit dilated. The systolic function is clearly impaired. It has what I sometimes refer to as so-called moth-eaten appearance. The right ventricle here, however, we could argue, are there some motion abnormalities? I really don't think so. The right ventricle here doesn't seem to be the dominant problem. And of course, where the money is on the late enhancement images, where we see scar within the interventricular septum here becoming subepicardial, here in the posterior wall, sometimes becoming much more ring-like in these appearances. So what do we call this? It doesn't appear to fulfill the classical criteria for ARVC. It seems to be dominantly affecting the left ventricle. So do we call this arrhythmogenic left ventricular cardiomyopathy because of the presence of ventricular arrhythmia? The ventricle is a bit dilated and poorly functioning. So is this dilated cardiomyopathy? Is this heart failure with mid-range ejection fraction? And here this is our problem. So we have a plethora now of new terms: isolated non-ischemic scar, arrhythmogenic dilated cardiomyopathy, left dominant ARVC, hypokinetic non-dilated cardiomyopathy. There's a lot of confusion now in the literature. And for that reason, I think one solution that many of us have been exploring, discussing, debating, is whether or not we use this term, arrhythmogenic cardiomyopathy, to describe these diseases without sort of trying to define the disease by any particular ventricular predilection. The challenge with that concept has been its definition. Now, this was one approach in 2019 from an HRS expert consensus statement. And its simplicity is in some ways beautiful. How do you define an arrhythmogenic cardiomyopathy? Well, first of all, you've got to have some evidence for ventricular dysfunction. And then, do they have an arrhythmia? Yes. So you call it arrhythmogenic cardiomyopathy. Straightforward, easy to understand. But is that really what we mean by this term? Because this embraces a huge number of diseases. They've listed some of them here: sarcoidosis, myocarditis, Chagas disease, amyloidosis. But of course, if you follow this algorithm, say, is arrhythmia present at the clinical presentation? No, therefore it's not arrhythmogenic cardiomyopathy. So you've got other cardiomyopathies or ischemic heart disease or hypertension. But if one of these patients then goes on to have an arrhythmia, do they then become an arrhythmogenic cardiomyopathy? Another approach pioneered by the Padua group, a center with enormous expertise and knowledge about ARVC in its classical form, was to say, okay, well, let's stick with the morphological and the functional criteria that we use to define ARVC. And if that's all you have, stick with that term, ARVC. If you have a structural criterion, fat, fibrosis, for example, plus one of these arrhythmogenic cardiomyopathy genes, what do we mean by that? But maybe desmoplakin, for example, then we call that a dominant left ventricular disease. And of course, if you've got a bit of both, you call it biventricular. I think this is a thoughtful approach, but I still don't think it fully deals with the problem. And it feels to me very much as though we're trying to force everything into the existing paradigm of ARVC. Let me show you again how you can get yourself into a terrible mess by doing this. Another desmoplakin mutation, 46-year-old. Now he presents with myocarditis presentation. Biomarkers, pain, arrhythmias, etc. Again, ventricular activity on 24-hour tape. Here's his electrocardiogram. Now there's no arrhythmia here, but this is a very abnormal ECG. Again, once more, low voltages. Again, you could say an inferior infarct pattern here, possibly some fractionation of the QRS complex. Again, there's arrhythmia with ventricular activity of at least maybe 3 different morphologies here. And once again, when we look at the imaging, here the ventricle is not particularly dilated. It's again has this slightly moth-eaten appearance. The systolic function is a bit down. This time, I think there may be, you could argue again, we could debate as to whether or not there's something going on here in the free wall of the right ventricle. So is this left ventricular disease or is it right ventricular disease? The MRI tissue characterization is very critical here, because here we see that there is indeed this ring-like pattern. There's nothing actually obvious in the free wall of the right ventricle. is a bit inferiorly. This is sort of very much on the right side of the septum, outside the classical triangular dysplasia. So is this DCM? No. Is it classical ARVC? I would argue no. Could you call it an arrhythmogenic left ventricular cardiomyopathy? I suppose you could. But it's basically an LV disease characterized by scar, no dilatation, with borderline systolic function. And I think this is not a rare phenomenon. I challenge anybody who's listening to me now who's involved in MDTs or cardiac imaging, particularly MRI imaging. This kind of stuff is present in everyday practice. Ventricles that are being scanned for various different reasons, patients presenting with heart failure, patients presenting with arrhythmia, patients being screeners for unexplained electrocardiograms, seeing all these different patterns, ring-like scars, mid-wall scars, sometimes being attributed to cardiomyopathy, sometimes to hypertension, sometimes to previous myocarditis. And this is where the seeing but not observing comes in. We can see the picture of the heart, we can see the scar, but we're not observing the phenotypes, because these different patterns represent different diseases. And the trouble we've had is we're trying to force these diseases into our existing structure of DCM or ARVC, or maybe even some of these other entities. People want a box to put this into. Okay, so let's examine what that box might look like. So we have a classification of sorts, it's a clinical descriptive nosology. So we could just say do nothing, which is effectively what we're doing at the moment, or tinkering with the existing definitions. We could completely redesign the whole thing. And in particular, we could move towards a more etiological-based classification. This is one of the debates we've had within the field of cardiomyopathy for many years. Stop defining it by the morphology and function, but start with the etiology. So we talk about desminopathies, or we talk about titinopathies. Personally, as fundamentally a clinician, I think that you need different types of classifications for different purposes. And when you're sitting in the clinic, what you're sitting there with are phenotypes. And I actually think it needs maybe just a bit of adaptation to the new diagnoses, new etiologies that are emerging to make this usable. I think stick with the paradigm we've used since the time of Wallace-Brigden. Cardiomyopathies are structural or functional abnormalities of the ventricles, which are not explained solely, alone, by abnormal lung conditions, hypertension, valve disease, or coronary disease. You have to have an abnormal heart muscle in order to be able to call it a cardiomyopathy. But what I would then suggest is that you don't need to define it at this stage by the presence or absence of an arrhythmia. Your starting point is that the heart muscle is abnormal. When you're thinking of what you then do, you have to say, okay, well, what is the scenario here? Let me explain what I mean by that. So, the way in which you interpret features on cardiac imaging or an electrocardiogram depend on the reason you're seeing the person sitting there in front of you. So if you see left ventricular dilatation, for example, if that person is an elite athlete with a peak VO2, which is 140% of his predicted, an endurance sportsman, then that is probably not a true structural abnormality. That is simply a physiological adaptation. Whereas if it is in a sedentary 50-year-old with some T-wave changes and a history of syncope, then it's a different scenario altogether. Similarly, if you're seeing a relative of an individual who is known to have a cardiomyopathy, hypertrophic dilated ARVC, and they have 1,000 ectopics and T-wave inversion in V1 to V3, then that is, even those abnormalities represent expression of the phenotype. So you think about the scenario in which you're seeing the person. You then describe what you see. This is pretty much what we do now. So we say, you've got a thick heart, you call it hypertrophic. If it's dilated polyfunction, you call it DCM. If you've got a stiff heart, which is neither dilated nor thick, you call it restrictive. Here you can stick to the existing criteria for classical ARVC. What we've been struggling with, I think, is a name for these left ventricular cardiomyopathies, which are non-dilated, but show scar, show impairment of systolic function or regional wall motion abnormalities. So why don't we just call them that? Non-dilated left ventricular cardiomyopathies. The arrhythmia bit comes in pushing you towards the etiological subtype. Now, we've put huge emphasis on ventricular arrhythmia, obviously, because that's the thing that kills you. But there are other arrhythmic phenotypes which are just as important in terms of diagnosis and indeed maybe in terms of the morbidity and mortality for the patient. Some of these phenotypes are characterized by a high burden of atrial arrhythmia and stroke. Some of these phenotypes are characterized by atrioventricular block. Other traits which push us towards a diagnostic category will include excessive trabeculation, non-compaction, if you will, or other extracardiac manifestations. And of course, one of the most important associated traits is the presence of a family history. And when you put together the scenario with the morphophysiological description, together with the presence of other cardiac and non-cardiac traits, then you start to observe and not just simply to see. So when this image I showed you earlier, you know, the ring-like pattern here in someone who's got a mild hair and skin phenotype, frequent ventricular ectopy, maybe recurrent presentations with myocarditis, this is desmoplakin. If you have a family history of sudden cardiac death, often in the presence of mild left ventricular systolic impairment, again with sort of often ring-like patterns here, high burden of ventricular ectopy, this could be filamin C. If you have a patient who has early onset atrial fibrillation, maybe PR prolongation, modest elevation of CK, mid-wall scar here in the septum, mild or modest dilatation of ventricle, impaired systolic function, that could be lamin AC mutation. Phenotypes emerge when you start to integrate these different sources of information. And then, of course, the final step in this pathway is determining the etiology, determining whether this is genetic or inflammatory or infiltrative or toxic, or indeed combinations of these different final pathways to disease. Now, there may be some of you are thinking, here he goes again, hopelessly looking back to the past, you know, to a time when physicians wore frock coats, listened to the heart, examined their patients. You know, is that really what modern medicine is about? Of course, we do live in very interesting times where we have new ways of looking at disease phenotypes or looking at healthy phenotypes, indeed, at scaling populations right down to an individual level. So, for example, from this very nice review by Ewan Ashley and his colleague, looking at how we might apply new technologies towards precision medicine in heart failure, not only do we have the classical phenotyping, but of course, we have genetic characterization, both looking for rare variants or common variants, the development of polygenic risk scores to look at high-risk clusters, to look for phenotypic clusters using machine learning approaches in large populations, to identify new clusters which maybe define new phenotypes, which are perhaps more aligned to both etiology and potential therapy than our traditional morphological phenotypes. And of course, this may be the way forwards. In cardiomyopathy in particular, I think we're living in a very exciting time where we have our phenotypes, but we're now linking these to the genetics of disease. And increasingly, although this is still always a challenge in cardiovascular medicine, to specific cellular phenotypes, which you can target therapeutically. But I would still argue that the phenotype, the cardiac phenotype, remains one of the key elements of this process towards improved outcomes for our patients. Phenotyping is critical in the interpretation of molecular diagnoses. Here, a position statement recently produced from the ESC Council of Cardiovascular Genomics, lead author Eloisa Arbustini, looking at how cardiologists, physicians, can contribute towards the interpretation of genetic variants. Many of you are probably familiar with the kind of criteria that are applied, ACMG criteria for interpreting variants. But as you can see from this figure, 8 of those criteria depend upon a clinical evaluation of the individual or their family. And or they may be based on functional evidence, for example, by looking at tissue characterization at a histological level or ultrastructural level. One approach is to say, well, we'll do the gene, we'll shoot first, if you like, we'll do the genotyping and then come back to the phenotyping. But my argument is you're going to have to do the phenotyping at some point. And if you don't do the phenotyping, then you will misinterpret the genetic results. And the other reason why I think phenotyping is so important is because precision medicine, the future of precision medicine in cardiomyopathies, is dependent on both an understanding of the etiology and the phenotype. The classical phenotypes are not going to go away. You know, whether you have a titin mutation or DSP or myocarditis, we're still going to be looking at what is the major risk to the patients. If they have atrial arrhythmia, we need to control the arrhythmia, restore normal rhythm, control the rate, prevent them from having a stroke. If they have ventricular arrhythmias, we're going to have to make a judgment call as to whether or not they're life-threatening, use drugs, ablation, defibrillators. If they have heart failure symptoms, we're still going to be using the emergent paradigms for management of heart failure with ACE inhibitors, MRA, et cetera, et cetera. If they have secondary valve disease, they may become candidates for edge-to-edge repair, transcatheter approaches, or whatever. So this still will happen. But layered on top of that will be our new understanding of etiology. Here's an example from Alex Prognatarius looking at the published model for stratifying risk in ARVC, which relies on a number of different parameters to come up with an individualized risk estimate. And what we've done here in this validation study is to look at the calibration of this model. So here, if you look at what we see happens with the model in terms of predicted probability compared to what the model predicts should happen, the closer this line is to that slope, the more precise is the model, the better is the calibration of the model. What you see in this cohort of patients with ARVC is that if you're gene positive, then the calibration is pretty good. If you're gene elusive, it's pretty rubbish. Amongst the gene positive cohorts, accepting this is a relatively small cohort, the best correlation is PKP2. So the genotype is influencing the performance of this model for predicting risk. If you look at this exploratory model, looking at individual clinical parameters that associate with outcomes, you can see here that in the PKP2 cohort, the classical ARVC things that we've been describing that associate with outcomes, so signs of right ventricular dilatation, non-sustained VT, the amount of XP you have, these are all positively associated with the outcome in the PKP2 cohort. But in the desmoplakin cohort, no. The only one for which there's any real signal here is impaired left ventricular function, showing that it's a different disease. It's a left ventricular disease. If you look within the noise, you find these signals. So this is from a study from Denver, Luisa Mastroni's group. So if you look at patients with dilated cardiomyopathy and see if they carry a mutation, they have a higher risk of ventricular arrhythmia and sudden death. If you look at individual genes, however, much higher. Desmosomal genes and laminopathies. They emerge from the signal for dilated cardiomyopathy, allowing us to better stratify patients for ICD implantation. Precision diagnostics related to etiology. This is the poster child in cardiomyopathy land at the moment. You can talk about HFpEF, or you can talk about what maybe 13% of patients with HFpEF have, which is Tto Amyloidosis. Why is it important? Because we now have a treatment, a stabilizer of the underlying protein that becomes deposited within the heart in Tto amyloidosis, transthyretin. And by giving that drug tafamidis, we can show in a population with a median age of 75, a 30% reduction in mortality and a slowing of disease progression. Etiology-driven therapy. This is not so much driven by the underlying molecular etiology, although time will tell here, but here we have hypertrophic cardiomyopathy with small molecule therapies targeting one of the drivers to the phenotype, hypercontractility at a cellular level. And here we can, in the Explorer trial, we can see by giving this small molecule inhibitor of actin-myosin interaction, reductions in gradient, reductions in biomarkers, N-terminal proBNP, reductions in troponin T. The future for cardiomyopathies is the linking between traditional phenotyping, but phenotyping based upon a description, a complete description of the phenotype, not just simply a wall thickness measurement or a left ventricular cavity dimension, together with the therapeutic opportunities that we now have. And I think in the next few years, we're going to see ourselves move very, very quickly, actually, from our traditional armory to a whole range of new therapeutic platforms, whether it be gene therapy, small molecules, immunotherapy, RNA silencing. We're only limited by our imagination. I'll close now with a couple of comments, just to go back to Wallace-Brigden, and again, 1956. Every case of suspected cardiomyopathy demands a detailed history, repeated examination, and elaborate investigation. By such means, the proportion of cases termed idiopathic should be diminished, and the whole picture of these interesting conditions made clearer. That has never been more true. Extended phenotyping, describing what you see and linking that to a molecular pathogenesis. And to give the final words to Conan Doyle, yeah, the world is full of obvious things which nobody by any chance ever observes. I think that's true, and I think unfortunately it's true of all human beings. It's how we work, it's how we assimilate information from the world. But the one that I think we really need to fight against, and one which I see repeatedly in my life as doctor, is this one. It is a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories instead of theories to suit facts. Don't ignore the inconvenient fact. Always try to seek the explanation. Gather as much information as you can in describing the phenotype, and thereby lies the future to improving outcomes in patients with cardiomyopathy. Thank you very much for your attention, and I look forward very much to the discussion.
Okay. Thank you very, very much, Perry. On behalf not only cardiologists, but also Sir Arthur Conan Doyle's fans, really an exciting lecture. I suppose there are many interventions from the participants. And if I correctly remember, the only way to participate in the discussion is writing the question.
Yeah, so you can either write at the Q&A button or in the chat, and we will read your comment out. You can also raise a hand, and we can try and give you audio access so you can speak up.
Oh, if I can begin, Perry, your representation, your beautiful representation of this disease, as for the relationship between genetic basis, myocardial substrate, and the arrhythmic risk, is quite honest. It's a honest disease. Genetic basis causes an alteration of the myocardial substrates, and the abnormality of the myocardial substrates produce electrical instability and possible sudden death. Is a quite different situation, for example, if compared with hypertrophic cardiomyopathy or with other cases of dilated cardiomyopathies, where the relationship between the genetic basis and the risk is more subtle. For example, is due to a sort of electrical instability, probably inside the cell. My question is, what about the risk of serious arrhythmic events in carriers of the mutation without a clear phenotypic abnormalities? Does it exist?
Yes and no. I mean, I think it's, as you say, I think one of the reasons I wanted to do this talk was I'm not trying to destroy the entity of ARVC, but I think we've grouped a lot of very different diseases under that umbrella or a version of it. I completely agree with you that yeah, you can see ventricular arrhythmias, you can see high ectopic counts, you can see atrial fibrillation, but it doesn't have the same meaning in every different etiology. So, for example, I think in the case of titinopathies, if you will, if you use that term, they're very twitchy, to use my horrible word. So they have a lot of atrial arrhythmia, they actually have a lot of ventricular arrhythmia, but actually for the majority of patients, nothing much happens until they become more end-stage disease. If you like, that's maybe more typical of the classical thought process for dilated cardiomyopathy. Conversely, if you have a filament C mutation, you may have some ectopy and an ejection fraction maybe of 45%. And if you look at this through the conventional lens of heart failure, what's the worry? You know, ejection fraction 45%, okay, there's 400 ectopics. That patient has a higher risk of dying suddenly. Not because they have 400 ectopics, but because they have filament C and a substrate, an unstable substrate, which can predispose them to fatal ventricular arrhythmia. Is it possible to die with a normal heart? With a completely normal heart with structured genes, I don't think that's very likely. I think you can have an apparently normal echocardiogram, and unless you do the MRI, you're not going to see the scar phenotype. So it might catch you out that the patient's got maybe, you know, a few ectopics, not a very abnormal ECG, a normal ejection fraction, and yet they could still have a high risk phenotype. But I think at a histological level, there is an abnormality. So I don't think it's completely analogous, for example, to ion channel disease.
Thank you.
Sorry. There is a question from Mario Ioannidis. He is asking if you have any tips for when we should suspect the existence of cardiomyopathy in cases of relapses of myocarditis, in quotes.
So I think this is a really, really intriguing question. And it's why I sort of hinted at it in one of my slides. I mean, we see patients as having myocarditis or cardiomyopathy. But what we're seeing over and over again now is myocarditis as part of the presentation of structural heart disease. As you know, some people on this call have heard me say before, you know, we are very slow sometimes as cardiologists. So for years, we talked about the hot phase of ARVC. What is the hot phase? The hot phase is chest pain, arrhythmia, elevation of troponin T, sometimes progression of the phenotype with new appearance of scar. Duh. What is that? That's myocarditis. And this sort of episodic myocarditis is something that I think is emerging, particularly with desmoplakin. You know, virtually every meeting I go to now, whether it be virtual or in reality, someone will get up and show a case of desmoplakin-related myocarditis. So I think it's understanding how those two things interact. How do you get from a structural gene abnormality to inflammation? What is the role of inflammation in the development of the disease, the progression of the disease? Does the inflammation come and go? What are the triggers for inflammation? But it doesn't mean they're separate diseases. I think in some instances they're part and parcel of the same disease process.
There is another question from the participants, in particular Jan Zvida. The point is, some types of arrhythmogenic candidates can be treated with beta blockers. I heard it could be reversible. Are the electrocardiogram changes also reversible when we treat patients with beta blocker?
I wouldn't say I've seen that or heard descriptions of that with beta blockers. I mean, I learned something on a recent trip to Australia about desmoplakin disease, where patients were presenting with the classical low voltage ECG, having an acute episode, and those patients had actually been immunosuppressed. And after immunosuppression, the ECG normalized, but they had a desmoplakin mutation. So I think there is maybe some plasticity with treating whatever the driver for the ECG phenotype is. But with beta blockers, I would probably argue not. I don't think there's much evidence that that would reverse the phenotype.
And there is another question about the utility of Pardo criteria clinically to diagnose ARVC instead of the original DFC criteria.
I think they're pretty much the same thing, to be honest with you. I mean, I think probably one of the biggest differences is the recognition that MRI and tissue characterization and the presence of scar is maybe something that's missing from the original task force criteria. But it's, again, I'm not trying to destroy the task force criteria, but I think we're making it too difficult for ourselves. I think describing the phenotype, as I've tried to show, you know, is there biventricular disease? Is it just LV disease? Is there scar? Does the pattern of scar associate particular genotypes? You know, if there's an arrhythmia or either atrial ventricular or AV block that helps push you in maybe a particular direction for a genetic diagnosis. I think that we're too hung up on hard and fast criteria, although I know that's how we have to think as physicians. But it's a much more integrative approach. It's not just simply about the presence or absence of any given criterion.
There's also in the chat a comment about non-compaction and where I was standing in terms of that.
Non-computazione. Okay, so so this is one of those perennial discussions. Okay, so non-compaction. That term, in my mind, has always been a very precise term because it implies a developmental abnormality. And it refers to the process of compaction during development of the heart, the embryonic development of the heart, whereby it has been thought that as the heart is developing, you develop these sort of frog-like trabeculae and recesses within the myocardium, and then these coalesce, compact into two layers within the ventricle, the compacted layer and the trabecular layer also forms papillary muscles. This entity has been described when, again, my analogy with developing stories. So it originally started with extreme phenotypes, kids with bad heart failure, high risk of stroke, high risk of progressive heart failure, high risk of sudden death. And then as we started to apply better echo, contrast, MRI, it was everywhere. And then we started to see it in what seemed to be completely normal individuals. So then it was being described in people who were athletes, in pregnant women coming and going. I think, again, it's a phenotype of excessive trabeculation. One of the problems of calling it non-compaction is, unfortunately, embryologically, that seems to be an incorrect term, at least in man, because actually the evidence that the compact layers and trabecular layers form through a compaction process is actually non-existent, and in fact it's the reverse. There's evidence that it doesn't form in that way. So to my mind, if you see excessive trabeculation, what is the scenario? Could this just be hypertrophy of existing trabeculae, as for example in a hypertensive or in an athlete, or in someone of Afro-Caribbean descent where the trabeculae are often more prominent? Is it occurring in someone with a family history of cardiomyopathy? Is it very extensive? Is it associated with other traits like malformation of the papillary muscles, in which case it's probably developmental and therefore in my mind implies a genetic etiology. But I think what you're going to see is a move away from the use of the term non-compaction and a term of excessive trabeculation. And then the question is, just as with ventricular dilatation or increase in wall thickness, is why is there excessive trabeculation? Is it developmental, or is it simply a reflection of the trabeculae are thicker because of increased afterload or some other similar phenomenon?
There is another question about electrocardiogram, and Robert Adam asked, can we see any electrocardiographic change in arrhythmogenic cardiomyopathy without any structural change on cardiac MR? So the link between MR and standard ECG.
That's a really good question. So I think if I think through examples, so in laminopathies, for example, I think sometimes the ventricular phenotype is not very very prominent in the early stages of the disease. So you might start to see, for example, some arrhythmias, you might see some conduction disease, you might see some subtle scarring in the mid-wall of the septum, but often there isn't that much scar. In mutations in BAG3, okay, another one of the important subsets of dilated cardiomyopathy, again, you may see some twitchiness, some ventricular arrhythmia. Actually, that's a phenotype where scarring isn't particularly prominent. Early phases of titinopathy, again, you may not see very much scar. So I think, yes, you may see subtle early ECG phenotypes ahead of something which is much more overt, even on MRI.
Many of the some of the cases you presented, Perry, were characterized by a generic diagnosis of mildly dilated hypokinetic cardiomyopathy with a pretty normal ECG or without any major abnormality. So, to quote Holmes again, the Hound of Baskerville, you probably remember Sherlock Holmes to Inspector Gregson, the strange episode of the dog at night, but the dog did nothing during night. This is actually the strange episode. So the importance of what is missing.
What is missing? Yeah, absolutely.
If you suppose that your patient has a dilated cardiomyopathy, but you cannot see any bundle branch block, any hypertrophy, any repolarization abnormalities, this can be enough to foster the suspicion of ALVC. Do you agree with this position, Perry?
Yeah, I mean, I think it's possible to have a normal ECG and to have one of these phenotypes, absolutely. And conversely, there are some mysteries about the pattern. So, I mean, loss of voltage in desmoplakin disease, that's a situation, that's almost like we'll be careful because there are pathologists on the line, but almost like a dystrophy. You know, so that really is, I think, loss of myocardium, and it's a really worrying feature in desmoplakin disease. It shows you've got advanced disease. Whereas sometimes you see patients who have increased voltage. It looks, to all intents and purposes, like a hypertrophic cardiomyopathy. So, what's occurring there within the cell? I think, yeah, as I said, these are data points. We may not have the explanation, but maybe by seeking the explanation, we'll understand more about the pathophysiology.
Can I just say that we also have quite a few family members that are gene positive, especially, let's say, with BRCA2 mutations. And even though they don't have any clear structural disease, we see that they have sometimes ectopy. And what do what do we make of that? Is that the kind of ectopy that a normal person would have, or is this part of arrhythmogenic cardiomyopathy or part of BRCA2 disease?
I mean, ectopy is a great example, Alex. I mean, you know, as you know, I obsess about it all the time. You know, are 200 ventricular ectopics a normal phenomenon? It depends on the scenario. So, you know, if you come from a family where there's ARVC, the odds are that person has the mutation, and that's their only expression. When we look at the kids, you know, this is work that Juan Kasky's doing and others doing in the children. The ectopy may be the only phenotype that the kids who carry PKP2 or DSP variant have. So ectopy is one of those examples of a phenotype which, if you go out into the real world and you see, you know, it's sitting there in a busy electrophysiology clinic, you can't say everybody with ectopy's got ARVC, but within a cardiomyopathy clinic screening a family, it's a really, really important trait. Just because there's not T-wave inversion or an epsilon wave or, you know, prolonged activation time, it doesn't mean that the patient doesn't have the disease.
There was another comment as well. So this is regarding if there are any treatments regarding, I think, the ARVC patients that can slow the development of the phenotype.
This is the exciting thing, isn't it? So I think in terms of conventional medical therapy at the moment, I wouldn't say we have evidence for that. The only signal that leaps to mind is in maybe the ability to reverse remodel the ventricle. And I think all the evidence would suggest that patients with titin mutations seem to be much more plastic, so they seem to remodel more easily than, for example, desmoplakin. I think when you get the kind of phenotypes we've been looking at today with that, a lot of scar, that doesn't get better with MRAs or RNAs or whatever. But the interesting thing about the new therapeutics, whether it be gene therapy or small molecules or RNA, is that, well, actually, we don't know what they're capable of. So, are they going to just arrest disease development? Are they going to reverse the phenotype? I think we're going to find that the phenotypes are indeed more plastic than we thought. But of course, the opportunity we have is preclinical diagnosis. The ultimate aim surely is to be able to say this patient carries a desmoplakin mutation, give them this therapy and stop them from developing the phenotype in the first place. And I think for the first time, with the kind of therapeutics that are now being looked at, that could become a possibility.
Any bets on the mechanisms?
For which?
You pick.
You mean mechanisms of disease or mechanisms of?
Mechanisms that you would create treatments for.
Oh, I see. So
like inflammation or
So so inflammation, possibly. I think what people are looking at the moment are things like gene therapy. So particularly in diseases characterized by haploinsufficiency, for example, they sort of lend themselves to that kind of paradigm. Although gene therapy itself, many hurdles to get over. It's difficult to get stuff into the heart, potential reactions to particularly to viral vectors, etc., etc. But I think for diseases where there's haploinsufficiency, potentially useful. Gene editing, it's been done in the liver, but again, it's not that hard to get stuff into the liver. But could this be a target for cardiac genes with cardiac expression? Possibly. Until we try, we won't know. I think silencing is, for me, is maybe a more tractable therapy. We've already got proof of principle again in diseases like amyloidosis. It may be possible that by silencing some mutations, we can actually, again, arrest or reverse phenotypes. So I think it's going to vary according to the disease gene, according to the type of mutation, according to the effect of that mutation on the cellular phenotype.
So probably the last question, if you agree, by Thomas Gosios. And the question is, would you consider multiple recurrence of myocarditis in desmosomal disease as a risk factor for sudden cardiac death? So the role of recurrent myocarditis in this disease is by itself a risk factor?
I don't know. That's something Alex might be able to answer quite soon, possibly, Alex. But I think during the myocarditis period, so when they're actually hot and inflamed, that probably is a vulnerable period. When you have episodes of myocarditis, that often represents, or is, you can actually see that the disease has progressed. So new scar may have emerged. Is the fact that the patient is hot or capable of being hot or recurrently hot a sign that they have a more dangerous or severe phenotype? I don't think we yet know. But I think that may come through a better understanding of what the immunological drivers are to disease. And of course, we need to scale that up into larger populations with prospective studies to understand the relationship between the immunotype, the phenotype, and subsequent outcomes.
So, thank you again, Perry. Thank you for your particularly brilliant lecture embedded within a detective novel. And thank you for bringing us from bench to bedside, and then to bedside, from bench, and then again from bench to bedside, many times in the same afternoon. Thank you indeed.
Elementary, my dear Claudio. Thank you.
Thanks all for joining. Bye-bye.
Bye.
Ciao.